Hi, everyone. Thanks for being here with us. I'm excited to get this session started. We often talk about means of integrating data upon collection, like standards or interoperability. But data linkage, whether joining records using direct identifiers or geographic area, is a post hoc means of integrating data to address limitations in a given data source. So I know this is a thing we talk about quite a bit, and I'm excited to learn more from our lovely presenters. So before we get any further in this session's topic, let me thank Cedar Bridge Consulting, our sponsor for this session. And now let me bring on stage Sara Herdman with Verato, who is going to be your moderator for this session. Sara, you have the floor.
Thanks so much, Charles. Hi, I'm Sara Herdman from Verato. We're the identity experts for healthcare. It's great to be here with all of you today, and I'm excited to be moderating this session, The Power of Data Linkage for Understanding Patient Outcomes. We've got 4 outstanding speakers today and lots of interesting material to cover. If you have questions during the presentation, just submit them in the chat, and we'll get to those as they come in. Our first speaker is Jessie Tenenbaum from the North Carolina Department of Health and Human Services. Her full bio and those of all our speakers is available in the speaker bio section of this session description in the meeting platform as well. So take it away, Jessie.
Good afternoon. I'm Jessie Tenenbaum, Chief Data Officer for North Carolina Department of Health and Human Services, and I'm delighted to be here today to tell you about IDHub, our pragmatic approach to record linkage for whole person health. So first, a little bit of motivation for whole person health. The business goal here is the ability to link data between the different previously siloed services we have around North Carolina to facilitate a whole person health approach to the people we serve. And this is meant to be at both an individual level so that we can have someone sitting in front of us and make sure that they are connected with the services for which they're eligible, as well as in an aggregate and analytical perspective to be able to evaluate and inform policy. In order to do this, it requires the ability to integrate across our different silos, which requires the ability to link between the different silos and understand what individuals are in multiple systems. So a few motivating questions we have. One is, what percentage of Medicaid beneficiaries have been vaccinated in the COVID context? Which children in foster care have prescriptions for more than 4 psychotropic medications? Who receives regular food referrals and would benefit from being enrolled in SNAP but may not be enrolled already? What percent of people experiencing homelessness have been vaccinated? And what is the relationship between early grade outcomes and different early childhood conditions? These last 2 are notable because they require integration between DHHS data as well as other departments across North Carolina, not just within DHHS. So answering those questions is currently difficult at best. This is shown here with the different colors. Our different systems, including our non-clinical drivers of health referrals, our COVID cases and vaccines, and our other communicable disease cases and vaccines, are all in different systems that use different identifiers. At the bottom here in green, you can see that we do have multiple systems that use the same identifiers, but still different from the ones I just mentioned. So it's difficult to link between those systems. So for example, when we wanted to understand post-vaccination cases in the COVID context, it was challenging to link between the 2 systems. Not impossible, but labor-intensive and prone to error. In order to achieve whole person health, we need 2 things. Number 1, the ability to integrate between the different data silos, as mentioned. And number 2, the ability to identify and link the same individual in these different silos. So for example, understanding that Jessie in one system is Jessica in another, or understanding that Waldo is in both of these pictures and has this identifier, making it easy to find him in both places. There's different options for solving this entity resolution problem. De facto today, each system uses its own identifier, and we've used probabilistic or fuzzy match on an as-needed basis to link between systems. As mentioned, that's labor-intensive and prone to error. Another option would be one ID to rule them all. If we had one identifier across the state, or even better, across the country, to identify people in a healthcare context and could just use that identifier, that would make analytics much easier. In reality, what we have is somewhere in between, where we have multiple different quote-unquote standard identifiers, and we have to map them to each other, making it easier to use that mapping when we want to do these different analyses. So just to be a little more concrete, what we're talking about here, you might have Angie Taylor at 12 Main Street. In one system, her identifier is 123. Her identifiers are sent to some authoritative source, which runs her through the system and says, okay, here is her unique ID, 100, even though her original identifier in that source is 123. Another system might send Angela Taylor, Angela instead of Angie, might have been a typo in the address. They send that information, and based on that address, maybe her date of birth, possibly a phone number or email address, they're able to say, even though it's slightly different, this is really the same person. So your system has XYZ, we're going to assign her 100 as her unique ID, and now we know it's the same person. And same for this third system. What this allows us to do effectively is to create one row for each actual individual, where we have a unique ID, 100 in this case, and it shows how it maps to the different identifiers from the different systems. And then we can just use that IDHub as a lookup when we want to do analytics and link between systems. There are a few challenges here. One is that these MPIs or master patient identifiers can and do change over time. They're frequently merged as more data are incorporated. Particularly in the MPI context, you don't want to merge two records unless you're really sure they're the same person. So you might have Jessie at address A with one MPI and Jessica at address B with another MPI, and you don't want to merge those unless you're really sure they're the same person. If you get additional information, for example, Jessie, the first name, at address B, the second address, you can see that it turns out those are actually all three records refer to the same person. Now we can give them all the same unique identifier. But that means that in some systems, what was originally MPI 222 has now been changed to 111. That's an easier case to handle than splits after a false positive match. If you were to merge Jessie and Jessica thinking they were the same person and then realize they're not, it's much more challenging to split those apart and make sure the downstream effects are understood. So the way we handle this in North Carolina is we have on the left our different source systems. From each of those systems, we send the source's unique ID, the name, the date of birth, might be email, address, phone number, anything that's going to help us determine who that person is. We send it to an authoritative source, in one case our health information exchange, and then they're able to look that up and see what the record for that person, what is the MPI. If there isn't already a record, they create one and send that back to IDHub in the bottom right, and that's effectively our mapping table that shows us the relationships between all these different systems. A few things to note about the North Carolina landscape. One is that we have a state-run health information exchange called NCDHHS. Another is that we have the Government Data Analytics Center, or GDAC. That's a division of our Department of Information Technology. It was created by legislation for data management and analytics. So this is part of their bread and butter to be able to receive a bunch of different data sources and be able to map between them. And then finally, North Carolina is home to SAS, which is a software company and provides analytic partnership for a number of our different departments. So unfortunately, as mentioned, we don't have one identifier. We actually have two identifiers in the state. One is the MPI I talked about, Master Patient Index. That's in the clinical context and has a very high stringency for when they're willing to merge two different records. We also, in the GDAC, the Government Data Analytics context, have what we refer to as an Enterprise Entity Resolution ID. Instead of different providers, that's mapping data between our different departments like education and commerce and justice. Slightly lower bar for when they're willing to merge two different records to say they're the same, because this is meant more for analytics, and a false positive is not going to result in combining different clinical data or a HIPAA breach. So as mentioned, we have those two identifiers. This is the graphic I showed before where our sources are on the left. We send the identifiers and get back an ID into our IDHub table. We actually do that to yet another authoritative source and get back two different identifiers. Not as efficient as we would like, but the system we're left with for now. It's worth noting that there's other options. There's third-party vendors out there. These logos are not meant to imply any kind of endorsement, but just a few examples of players in this space. It can be done as a service where you send your identifiers externally and they send back an identifier to you, or as off-the-shelf software done in-house where you're just using your own data. You get a lot of power either way by integrating additional data sources, as I mentioned, to sort of triangulate those records. There's a few lessons we've learned here. Number one is that this stuff is hard. The devil is in the details and those edge cases, and there's always edge cases that we did not anticipate You can imagine that twins and divorces and adoptions can be very challenging to determine whether or not something is actually the same person or not. It's going to take longer and cost more than you might expect. Do those memorandum of understanding understanding early. You want to make sure to get the legal documents out of the way. You're going to be sharing identifiable data. Concrete wins can help keep momentum, and it's related to the next point, that the businesses don't always understand why we're trying to do this. And so giving them examples of how this is making their lives easier and better can be very helpful to keep the momentum going. Also make sure to do a formal assessment of the accuracy for whatever system you're using, understanding what your false positive rate is, what your false negative rate is, and that can differ depending on the different data sets. And finally, COVID was great for spurring action and upfront funding for this, but ongoing funding is needed for additional data sources and operations and maintenance. And that's a challenge to anyone working in state government. Thank you so much for your attention. I look forward to the discussion.
Thanks so much, Jessie. I encourage people, again, if you've got questions, go ahead and enter them in the chat. In the meantime, I've got a couple of questions for you, Jessie. I'm wondering, what are the biggest technical challenges for matching records like you've described?
Biggest technical challenge, I think, are some of our older systems. So in an ideal world, we would be doing all of this real time. We've had to settle for kind of batch updates on a daily or nightly basis. We'll see where now the good news to that is that our use cases, most of our use cases, that's sufficient for our analytical purposes. But as we move forward and want to do more of the real time, we're going to need to upgrade both our sort of system integration systems and the systems themselves to be able to do more transactional real time interaction with data.
Makes sense. And has there been any effort to create a federal master person index?
I wish. I mean, so there's been effort for that in certain camps. Unfortunately, there's some legislation that was passed some years ago that basically precludes even the possibility of researching what the issues would be for such a national identifier. I think that wording was removed from the House bill that was passed at some point in the last year or so, but it's still in place in the Senate. Don't quote me on this, but I believe it's Rand Paul who stands in the way. So if anyone's in his state, maybe make your voice heard and say we really need this. It would help. In a different session I was in, someone said data silos kill people. And without this identifier, people worry about security and privacy. These identifiers don't make it so that you lose your security and privacy. All of the rules still apply. It just makes it so that we're less prone to accidental merges and splits and a lot of data exchange that doesn't need to happen.
Yeah, agreed. Data silos kill people. I think that's, I agree. There's a couple more questions coming in now. How do you measure false positives and false negatives?
Right, so that is challenging because really you need some kind of gold standard. You need some kind of truth. And in some cases, when you look at it, I've worked on projects where you look at it and even a human being staring at the entire record will go, is that the same person? I'm not sure. I'm not sure if it's a typo. And so for the most part, if a human being stares at it, you can find it out and get to sort of a close approximation of truth. In some projects I've worked on, it requires calling the actual person to say, hey, did you used to live at this address, or do you go by this nickname, or whatever it is. So it's labor intensive to get that false positive, false negative count, and it depends on the population you're looking at. So if you get an accuracy estimation for a given population, it might be very different if you're looking at, say, younger people or a significant number of Latinx or Hispanic names, because there's a lot of differences in spaces and order and multiple middle names and that sort of thing. So it's a challenge. Hurdles linked with linking state data with data collected federally. So obviously the linking ID is the one big hurdle. Another huge issue is that there's disparate regulations and laws that apply. And they can be in conflict with each other. So you can have different rules applying for what you're allowed to do. So you really need to involve your lawyers very early to understand what the federal laws are, what state laws apply, and how to reconcile those when there's differences. You mentioned problem, so I'm just going to reading. Problematic linkage, probabilistic linkage is time consuming and problematic. When assigning MPI or using any probabilistic methods or only deterministic matching using the available PII. So depending on the system, we have a few different places where we've done it. And then we work with, as I mentioned, our HIE and GDAC, our Government Data Analytics Center, and SAS. And so the different algorithms have different ways of approaching this. But the initial kind of record linkage uses probabilistic matching. So it'll say like, well, it's only off by a character, so it's more likely, with everything else matching, it's more likely to be a typo. And they identify that the ID for that person. Once they have an ID, then it's just the deterministic linkage of that single ID. Right, the accuracy.
We have time for one more before we need to move on to the next presentation. So choose one, but we'll get to remaining questions at the end.
So we already talked about the accuracy. When linking across data sets with different regulatory, does the most stringent level apply to linked data? Usually, I think that is the case. I would have to think carefully. I can imagine a scenario in which you can do a little of both, kind of do the more stringent where it's needed, but the less stringent for certain aspects. But I think it really is going to depend on the use case. And often that is going to be the lowest common denominator has to be the default of that more stringent one. Thank you for the questions.
Absolutely. And thanks so much, Jessie. Our next speaker is going to be Michelle Hendricks from Comagine Health. So we'll have Michelle up next.
Hi, my name is Michelle Hendricks. I'm a senior research scientist at Comagine Health. And today I will be presenting using a linked data set to examine patient and prescription factors associated with opioid overdose after an initial opioid prescription. If you want more information about this study, you can see our paper published in JAMA Network Open. Research imported in this work was funded through an NIH grant. We have no conflicts of interest to report. So individuals who have never had an opioid prescription before, but are getting one for the first time, this creates a potential for future opioid harm, such as overdose. We'd like to better understand factors that influence whether or not someone who has an initial opioid prescription goes on to experience overdose, but data limitations have made it difficult to get a complete picture in the past. So for instance, a lot of researchers use claims to study these issues, but claims are limited because if somebody loses their insurance or they transfer insurances, you can have incomplete data as a result. Also, claims data doesn't include certain outcomes like opioid-related death. So to address some of these limitations, we created the Comprehensive Opioid Risk Registry, or CORE. So CORE includes Oregon's voluntary all-payer all-claims data, APCD, and that has been linked to multiple public health data sets, as you can see here. For this study, we use data from the APCD, vital records, hospital discharge, and the PDMP. So the APCD is the base data set, and it provided information on patient characteristics. It was the basis for our cohort, and also provided information about ED visits, opioid-related ED visits. Vital records death certificates provided information on opioid-related deaths. Hospital discharge data was a source for opioid-related hospitalizations. And one of the benefits of this data source over claims was that these are provided regardless of payer, unlike claims. And then PDMP provides data on substances dispensed from all retail pharmacies in Oregon, also regardless of payer. So if somebody pays by self-pay, they're still included in this data set. And so this was our source of opioid-related prescriptions. Our sample was opioid-naive patients who received a first opioid prescription in 2015, which we termed the index prescription, and we followed them through 2018. So we excluded anybody who appeared not to be opioid-naive. So if they had any opioid prescriptions or opioid-related ED visits or hospitalizations in the 12 months prior to the index prescription, they were excluded. If they had more than one index prescription or an opioid use disorder-related buprenorphine index prescription, they were also excluded. If they were not continuously enrolled in 2015, we excluded them because our non-fatal overdoses are partially derived from ED visits, which come from the APCD. So we needed to require continuous enrollment for that reason. And then if they were under age 18 or missing age or gender, they were excluded. So for non-fatal overdoses, as I said, these were derived from ED insurance claims and also hospital discharge inpatient records using opioid poisoning ICD-9 and 10 codes. Fatal opioid overdoses were identified from vital records using ICD-10 underlying cause of death with multiple cause of death codes. And we also looked in the literal text fields in the death record using a tool developed by the Council of State and Territorial Epidemiologists. This tool allowed us to search those text fields for terms that might be suggestive of opioid overdose. Our outcome was operationalized as days from the index prescription to an overdose event or censoring. So censoring just means that they left our study before they could experience the outcome. People were censored if they lost continuous insurance enrollment. So we required insurance enrollment for 2015, but if they lost it after that time, they were censored. If they had death from a non-opioid related cause or reached the end of the study follow-up period on December 31st, 2018 without experiencing an overdose, then they were also censored. Our patient characteristics included demographics, age, sex, and race and ethnicity. Because the APCD had very incomplete race and ethnicity, it was about 50% missing, we imputed race and ethnicity using the Bayesian imputed surname geocoding algorithm. Insurance enrollment was ascertained based on which payer patients had for at least 6 months of 2015. We did not have Medicare fee-for-service available to us at the time of this analysis, so note that we only include Medicare Advantage in this. Also, we flagged comorbidities and pain diagnoses in 2013 and 2014. We also classified the urbanicity of patients' residents in 2015 based on their county of residence and using the National Center for Health Statistics urban rural classification scheme, which was kind of boiled down to metropolitan or non-metropolitan area. And for prescription characteristics, we had either index prescription characteristics, which were the characteristics of the initial opioid prescription itself, or characteristics in the 6 months after that initial opioid prescription, which we termed the index period. The index prescription characteristics here in orange were either drug name, whether it was long acting or not, and day supply of either greater than or 7 or greater or less than 7. Index prescription period, we looked at a number of factors, including the number of additional opioid fills in that period, the total sum of dosages during that period, the number of benzodiazepine fills, the number of, or whether or not there was opioid benzodiazepine overlap in day supply, and also whether they had fills from 3 or more pharmacies or 3 or more prescribers, and both of those can be indicators of doctor shopping. Our statistical approach was a time-dependent Cox regression model. Our index prescription measures were modeled as a cumulative time-dependent measures updated monthly through the 6 month of follow-up. So because the reason we did this was because the index period actually occurs in the 6 months after the onset of the initial opioid prescription. And during that time, we're also looking for outcomes. And so it's possible that somebody could have an overdose, say at month 3. So even though we were interested in looking in sort of the prescription characteristics in the 6 months after that initial opioid prescription, we had to account for the fact that an overdose could actually occur at that time. We had a bit of an overlap between our exposure and our outcome. So treating it as time dependent in this way allows us to, if an overdose occurs in say month 3, we can only, the model will only look at measures prior to that overdose as predictors. As opposed to looking, we don't want to have 6 months of measures predicting an overdose that happens at month 3. And so also all models control for patient and index prescription characteristics. So here are our results. Out of 236,921 opioid naive patients, 667 experienced an incident opioid overdose in the study period. And you can see here hazard ratios. And just in terms of interpretation, if a hazard ratio is 1 or greater than 1, that indicates a higher risk of opioid overdose. If it's less than 1, that indicates a lower risk of opioid overdose for whatever group we're comparing it to. So for example, for age here, we can see that those individuals age 75 plus had about a 3.2 times greater risk of opioid overdose than those age 35 to 44. And for gender, males had a higher risk of overdose than females. In terms of insurance, anybody who had dual eligibility, Medicaid or Medicare Advantage, all had a higher risk of overdose compared to those commercially insured. And dual eligibility was particularly high. It was the highest one in this model at almost 4.4 times the risk of overdose of those with commercial insurance. In terms of comorbidities, particularly substance use disorder was associated with greater risk of overdose, about 2.7 times greater risk than those without a substance use disorder diagnosis. Also, depression was associated with higher risk, and having one or more medical comorbidities, and it got higher. Like if you had 3 or more, that was even higher risk. If you had oxycodone or tramadol, those were both higher risk of later overdose relative to getting codeine. And also certain measures of risky prescribing in that index period were associated with greater overdose risk. The highest one was actually that opioid and benzodiazepine overlap. So if they had day supply overlap between those 2 drugs, then suggesting that they had those 2 drugs at the same time or taking them at the same time, then this was associated with 2.1 times greater risk of opioid overdose. So in conclusion, elderly age, having Medicaid or Medicare coverage, but especially dual enrollment, comorbid substance use disorder, depression, multiple comorbidities, and male sex were all associated with overdose risk. Oxycodone and tramadol also may be more risky drugs to prescribe as that initial prescription compared to other types of opioids. And this also confirms previous findings on the danger of co-prescribing benzodiazepines and also doctor or pharmacy shopping. That's all I have. Thank you very much.
Thanks so much, Michelle, for such an important presentation. I'll encourage people again, go ahead and put your questions in the chat for Michelle so we can learn more about the work she's been doing. I think I'll start off, Michelle. What were the challenges or maybe kind of lessons learned in linking several data sources to your APCD data?
Yeah, I think my answer is gonna sort of be similar to some of what Jessie said in her last presentation. You know, we don't house any of those data sets. Most of those data sets are housed at the Oregon Health Authority. And so it was interesting where we house the APCD, or at least the voluntary APCD here. So we had that, but we had to reach out to them to get the data sets to link for this study. And so they, you know, basically building in time was really important because we had to go through a process, you know, with them, a process of them learning about our project. And then also there were about 5 data stewards that we had to sort of coordinate with and sort of work out a plan. So a lot of planning went into this upfront to make sure that it was going to work for all of the data stewards, which meant a lot of conversations. And then also just the process of going through getting those data requests approved, the back and forth involved. I think it took us about a year just to do that aspect of it, and that doesn't even involve. I think it took us about 2 years before we had a full data set, because then there's also the work. You know, we have to once we get the access to all those data sets, we have to put them together. We geocoded about 3.5 million records in the APCD, which took some time, and so yeah, it between sort of setting up all that administrative documents and then also doing the work itself, it takes definitely building way more time than we knew it would take a long time, but it took even longer than we thought it would take. So lesson learned was just to build in that time.
Really helpful. I have another one here. How is a member assigned a payer? What happens if a person has opioid prescription from commercial prescribers, but follow up with a dual or Medicaid prescribers?
Well, our PDMP data includes all prescriptions filled at outpatient pharmacies, so it doesn't matter whether they filled it with a prescriber under Medicaid or under commercial insurance. That was actually one of the benefits of using the PDMP, because it wasn't tied to insurance at all. And so no matter how they paid or how they managed to get that prescription, it shows up there in the database.
Got it. And why do you think oxycodone and tramadol increase the risk of overdose compared to the other opioids?
I can definitely speak to oxycodone. We did some follow-up analyses with that, and because oxycodone and hydrocodone are the most two commonly prescribed opioids in Oregon. And we found that hydrocodone is pretty much always prescribed in a combination pill with acetaminophen or some other pain reliever. And so when people receive that drug, they tend to ingest less dosage, less MME, and having higher MME is a risk factor for later overdose, whereas oxycodone was more of a monotherapy. And so people were getting more opioid basically. And we think that may play a factor. Tramadol, we do hope to look into that in the future. It's a pretty small amount of people who get tramadol, so I am curious about what is it about people who get maybe there's something about that population of individuals. One limitation of our study is that we really didn't know why people were getting these drugs. We didn't have information on why they were prescribed in our data set. So I think it would be important to look at that in the future too.
Thanks. There's a question here. Michelle, would you consider a check to see if the patient received drug treatment for opioid use disorder? For example, naltrexone, that might cause a decrease in overdose risk.
Yeah, I mean, we didn't deal with that factor much. So that was sort of an exclusion for this study. If there was any evidence that they were receiving MOUD or, any medication for opioid use disorder, we didn't exclude them. We kind of called them not opioid naive. So because this study was particularly focused on people who are opioid naive, but I agree that it's a very interesting question to look at people who are receiving treatment, and in the future I'd like to follow up with a non-opioid naive population as well.
And maybe we have time for this one more here. What data did you use from the American Community Survey?
Oh yeah, so we use the Social Vulnerability Index. Is one we're actually just now doing. That's our third aim, is to look at community level factors, and we're just getting there now. So we're I know we have some socioeconomic indicators. The Social Vulnerability Index is sort of a composite of a bunch of those different indicators. So we'll be using that as well. And I'm looking forward to those results.
Excellent. Well, thanks so much for the really great presentation. We're going to move on now to next up. We've got Kari Degerness and Megha from the Center for Improving Value in Healthcare.
And welcome to our presentation on high-value care at end of life. I'm Kari Degerness, Director of Healthcare Programs, and I'm joined by Megha, who is our reporting analyst working on this. Most of you do know about CIVHC, but wanted to just mention we're in Colorado. We manage the all-payer claims database, which is what helped to support the back end of this with the data. A little bit of background on the programmatic stuff is that we've focused on bringing individuals together and helping to address some of the biggest challenges, including palliative care, care transitions, and we also look to partner that data with those programs, which is where we bring ourselves to this project. The goal of the project is really to inform the work that's happening in serious illness, help improve palliative care services, advanced care planning, and also looking at disease trajectory and planning for those. A little bit more about the project. We do break this down around cost, utilization, and quality. We are using decedents in Colorado and looking for years preceding death. We want to make sure that this is a unique study by looking at all different payers instead of just traditional Medicare. Some of the key components are around that advanced care planning and palliative care services, which is something that we work very hard to really improve upon here in Colorado. We are doing this iteratively, and we also hope to work with other states that are also able to do similar studies. A little bit about how the data was filtered. We sent over members who were over 18 from the all-payer claims database to our Department of Public Health and Environment. They matched to decedents in 2019 and 2020 and sent those back. We removed traumatic deaths as we did not want to include those in the population, as we're looking for more natural deaths. We also wanted to remove any dates of death multiple claims with dates of death multiple claims after the date of death, sorry. And so that we had actual decedents, because if they had multiple claims, they likely weren't actually dead. So we wanted to remove those. We also wanted to make sure that there was sufficient claim trajectory to do proper analyses. So we did remove anyone that didn't meet those criterias. And as mentioned, we pulled 4 years preceding those deaths in that population that we just talked about.
Thank you, Kari. I'll take over this section. This is analysis we did, and how Kari mentioned, the filtering resulted in a study population of about 37,929 unique persons or individuals. We did a demographic breakdown into it. And as you can see, there are two analyses here for age and gender. Age, as you can see, our population is about more than 60% in 75 years or above. Age was divided by 10 years increment, the two extreme beings under 45 and above 85 years. As you can see, gender breakdown, female is to male ratio was somewhere around 51 to 48% and 1% as unidentified. We also did race and ethnicity analysis. Non-Hispanic or Latino whites were about 63% of the population or cohort for this study. We further deep dived and divided our analysis into three major sections. Population description, which were demographic, place of death, diagnosis groupers and primary diagnosis for such population. Second is cost measures, which was done by each pair, by claim type, and also breakdown by year before death. Year before death is unique parameters which we developed for this population, which since we were looking back for 4 years before date of death claims, we divided each of them based on the date of death by last year before date of death, second to last, like that, fourth to last years. Utilization measures, we did somewhere around 10 measures, and as you can see, we have listed them here. We will talk about some of them moving forward. The unique thing about this population or this analysis was this was done across all payers. So we have 4 major payer population: Medicare Advantage, Medicare Fee-for-Service, Medicaid, and commercial. But we also have dual populations. Duals are people, those who have enrolled in either Medicare Fee-for-Service or Medicare Advantage along with Medicaid. A maximum population or the largest chunk of the cohort was in Medicare Advantage, followed by duals, Medicare, Medicaid, and commercial. Just a caveat to this analysis, one member can have multiple payers, and that's why our numbers are, or the unique members overlap among payers. Utilization measures, here I'm showing you about 3 different measures which we did was advanced care planning, observational stay, and ED visits. Here you can see the 2 y-axis are visit or claims. Visit or claims are the number of occurrences with advanced care planning, observational, or ED across all years by pairs. So this is all 4 years data. Percentage of total is unique members with occurrence of such kind of measure by the total population of that pair specific. Advanced care planning, as you can see, they have highest numbers or visits by duals, but and the highest percentage of the utilizer within the population was in duals as well. As you can see the breakdown, Medicaid, Medicare Advantage, and duals are leading here. Same with observational stay, Medicare Advantage is highest in the population using such stay with highest number of utilization claims as well. As you can see, commercial has lower across all the three measures. ED visits is kind of consistent across this all pair with Medicare Advantage and dual leading the counts. Although the highest utilization count we can see, or the visits or the claims we can see in dual population. The main point of this analysis was palliative care. And as you can see, we have divided the population by last year, second to last, third, and fourth. Unique number of unique members per each year we see highest in last year, which was expected of this population, but there was huge jump between second to last year. Although the Z code, which was the palliative code and counter for such population, is consistent across all 4 years. Palliative care is usually not easily found because it is not reimbursable in many states. We are still looking into this, and the next phase will include HEDIS scores by providers with a palliative care certification. Last one of the measures I want to talk about is the cost by payer, 4 years across their date of death. And as you can see, different color coding was done for 4 years. Highest on the major chunk was in the last year of such high spenders. Highest population spenders were duals compared to then Medicare Advantage and Medicare fee-for-service. For next section, I'll ask Kari to talk about key insights.
So we found some key things that we wanted to just make note of. As you saw, the Medicare Advantage has quite a few of those utilizations, and we know that Medicare Advantage plans are growing in number and frequencies, and so we better want to understand that and some of the drivers of costs and services that those folks are using. We noticed that the last year preceding death has high use of services, which is maybe not the best thing because we want those end of year lives to be really quality, and going in and out of the ED or the hospital is not necessarily what people really want. And it's also not necessarily the best use of care. Additionally, advanced care planning conversations, while it's great that they are being had, as we know from the data that's coming in, it's happening in the year preceding death, which is not necessarily the best thing, since in the last year you may have multiple things happening and you could receive care that you haven't really wanted, but you haven't identified that in your advanced care planning toolkit. So we want to be able to move those conversations sooner than the last year. For next steps, we really want to bring in some more information to better understand the bookends of the pandemic and the COVID-19 information. So we're hoping to pull in 2018 and 2021 and do deeper dives on that COVID population within the study population currently to better understand that. Additionally, home health services are something that we do want to look in because the billing for those are very different in the Medicaid and Medicare, and want to better understand that and ensure that we're comparing apples to apples. Pharmacy is also a big one that we would like to bring in, and we're working collectively with our partners to really make sure, again, this is actionable for their populations. I want to thank you, and we look forward to questions.
Thank you.
Thank you, Kari and Megha. And I'll ask again, if folks have questions, please put them in the chat. Looks like we've got one here already. The difference in cost between the dual and other types of payers is quite large. Do you have an idea of the reason?
I'll take that. Yes, the main reasoning being dual population is they are mostly high utilizers, and they are duals because there are services which are covered by certain kind of payer and not the other one, and hence the total cost utilizer cost is kind of an add-on. And that's why we see such high jump in dual and Medicare Advantage population.
That makes sense. I have a question. How do you think that COVID has affected the results, knowing that data from the 2020 deaths are included in the study?
So we did an analysis based on the death by 19 and 20, and we found that our population, which is such very specific population, is divided as 45:55, so high number of high number of deaths in 2020, and we will see that in the overall population, about 8% has COVID as a cause of death. So it certainly has affected this population, and that's why, like I mentioned, we would like to see how the control years like 2018, which was pre-COVID, and 2021, which is post-COVID, fare with such population and how the utilization varies.
Makes sense. And did you encounter any challenges in linking the data from the all players, the APCD and the death record registry?
I can actually take that one. So when we've been trying to do this project for a while, and so we had quite a bit of time to work with the public health department and figuring out what we could send over. And one of the challenges that actually was very surprising is that we actually basically took the all payer claims database from Colorado, had to send it to CDPHE and match from there. They couldn't just give us a list of those decedents and send it to the APCD, and then we work from there. So that was one of the unique things that we had to find a way to send that basically a copy over, and then have that matching process start. So
Interesting.
yeah.
Another one's coming here. Do you shift from Medicare Advantage to Medicare fee-for-service in years before death?
We haven't actually looked at it like that. So I think that's a good question to kind of look and see whether or not that's happening within the population. We do know that there are populations when they go into hospice to remove that Medicare Advantage population. There's some encouragement, especially if you're in a long-term care community. So we do expect some of that to happen, but we haven't yet looked at it. So thank you for that question. Hopefully we'll have an answer in the next phase.
Absolutely. What made you decide to report on palliative care when you knew of the limitations in the claims data?
It's been something at the center of CIVHC since we actually started, and something that is really important and starting to expand. There's more states that are helping to build those into Medicaid services, and Colorado is one of those. The Medicaid department is helping to fund this project, and they're very interested in seeing how that palliative care benefit could be a value to the Medicaid population. So while it's very challenging, we do want to try and see what we can find and be able to inform that work that we're doing, and hopefully be able to bring palliative care services to more Coloradans.
Thanks. Maybe one more. You mentioned that you're hoping to have this be replicated. How do you see other states beginning a project like yours?
You want to take that one, Megha?
Yes. So when we did the background research on this, is such kind of reports mostly comes out from the countries where they have standardized or general health insurance, like Canada or Scandinavian countries. So this is our first take on multi-payers. A few states, Medicaid department has done, California being one of them. They had done their analysis based on on this project, but we wanted to see how different payers play across the board and how we can make this population get better care. What we want to do is, once we have our methodology robust enough with all multiple institutes or multiple people, those who are interested, we would like to share that with other APCDs to have it replicated, or if they're interested to look into. Maybe federally, don't know, future is vast.
Thanks so much. Well, thank you, Kari and Megha. That wraps up our prepared remarks, but with the remainder of our time, we can take more questions from the group, from the audience. So please go ahead and put questions for any one of our presenters in the chat. Maybe I'll start by asking just a general question out to the group, and anyone can grab it first if they want. But, you know, was there anything that you wished you had included in your presentation, or wished you had said that, you know, having heard some of the questions come in, or having listened to each other's, that you'd want to add now?
I would have liked to include it, and this is a kind of a question to Jessie as well, is what was the dropout rate on the matching thing? We had to send our data to CDPHE, we got their match data, and since we use our own unique identifier, each pair has their different identifiers, so we had to kind of drop quite a considerable amount of member IDs. So my question with Jessie is, how do we deal with that, and what is the dropout rate of your study?
Yeah, it's a slightly different thing for us, because if we send a record and they don't have a match, they create a match for us, and then we get that identifier moving forward. And then probably, I don't have quantitative data on this, but you may have that situation to describe where you have what we thought was two different ones and say, oh, it's actually the same person. So we merge it later, but we always do get something back that we can then later potentially merge in.
Thanks for that. There is a question that's come in now. I'm going to read it. It's kind of long. The advantages of linking data across data sets are compelling. Have any of the panelists encountered a potential use case when they questioned, should we be doing this? For example, due to risk of social or economic harm to individuals. Is de-identification a sufficient protection in such cases?
I think
That is such a
I
great
can.
question. Go ahead.
It is a great question. Yeah, and I can start with that because I think that was, since we had linked so many data sets together, that was a big concern going through the whole process. And I think all of the data stewards had some concern about that. And especially, I think Elizabeth had a question earlier about like, does the most stringent statute apply when you're linking multiple data sets? And for us, that was definitely the case. So the PDMP in Oregon has the most, they had the most stringent statute around de-identified data. And we took a lot of steps to make sure that we couldn't re-identify people and that the data set that we were using was sort of the minimally necessary. That was one of the big requirements for them. So we did all of the linking first and designed our linking methodology very closely with the PDMP program to make sure that what we were doing wasn't going to result in any re-identification. We also took steps like, so us on the research team didn't have any access to any of the identifiers. We had somebody in another department in Comagine who actually did all of the linkage, and that person didn't have any wasn't on the research team. So in that way, like we never have access to any of those identifiers and use the most minimally necessary data possible, which meant that in some cases we would collapse things like age. We weren't just like, we wouldn't have something like date of birth, of course, in our data set, and we or even like an age year, we would like collapse it into categories, even like census tract variables, collapsing them just so that it's not obvious. You can't for one individual pinpoint that they're like in a specific they're a specific age. Or even have a specific diagnosis. So in a lot of cases too, we combine many diagnoses together into a group rather than have like a diagnosis code associated with it. So we took a lot of steps to avoid such a thing.
I would like to add on to it. Thank you, Michelle, for explaining that. Since Civic, we do a lot of reporting as well. So we follow CMS suppression rules. So if we have any services or any count which is less than 10, we tend to suppress and not show it to public at all, if with any bifurcation elements for the demographic. As well as Civic does is we create our own identifier. So you could have a member ID from different pairs, but we only see, means the analyst only see a member composite ID which we create, so that we don't identify that person in day-to-day life as well. So we take a great steps in de-identifying such population. And since we also share our data, we mostly send mostly de-identified data to most of our clients. Only in certain very stringent rules and regulations, we send them complete fully identified data. So there are huge steps and rules and regulations placed so that we just don't identify anybody in person.
The things I would add are that, so this is highly related to just the sort of data integration in general. I think that in all cases, bad things can be done with the data. I think in all cases, there's appropriate, sometimes potentially too stringent or at the very least confusing rules about what you need to do. My colleagues and I joked during COVID that like small cell suppression was going to be the death of us, because small cell suppression is great, but it gets complicated and there's different rules applying in different places, and it was crazy. So I think the important thing is to anticipate exactly this kind of question. Say, are there things we shouldn't be doing with this? And make sure that people don't do those things. It's not the data linkage itself, it's what's done downstream.
That's really good.
The one thing I would add to that is, I know, and my past is working in the mental health space, there's certainly concerns, even with, I mean, we look at whole person health and want to integrate physical and mental health. There's sort of a known phenomenon of physical health providers who, if they find out about a mental health or substance use disorder past, may dismiss legit physical complaints from patients. And so I think that's the use case that comes to mind. But that's, I think, very different from most of the stuff we're discussing. And I think a lot of people would stop short of saying, yeah, your doctor shouldn't have certain information about your health.
If I could just add one more thing, that's something that we're trying to do with information is to help the trajectory of care. And so if you're diagnosed with something, what kind of services are you going to need in years 3, 4, 5 of that? And I think we do need to be careful with that, to not just assume that every person diagnosed with the same diagnosis will require all of these services, which might make individuals make certain decisions, such as moving away from a rural to an urban area that has care and services available for that disease specifically. So I think that's a good question to just keep in mind, and making sure that we're not making solidified recommendations or anything that says this is concrete. We're not medical, physicians or anything like that. We need to be careful about how that information is presented, and making sure that it's not misinterpreted and causing that harm. So I think that's a good question to keep in mind.
I had I see a question in the chat. If we have time, I'll ask my question to the other panelists.
Okay. Yeah, there is one more in the chat. A common theme was getting the data owners involved early, and it takes time to work out details on data sharing. Any advice on this step? What would you do differently next time?
Get them involved early again. And keep reinforcing the messages that they need to hear, of like, you're not losing control. We're trying to help facilitate things that you want to do. This is not a matter of people trying to steal or even take your data. You own the data. You still get to make the decisions. We're just trying to facilitate those analyses.
And I would add to that also, I would say start with the agency that's the most stringent in terms of the requirements and kind of work backwards from there. Because if you can meet those most stringent criteria, then it'll find it easier to meet all the criteria of all the other data stewards later.
That makes sense. I do think we have about 1.5 minutes left, Jessie. So if you've got a question, go for it.
Yeah, for Megha and Kari, I was interested in the observation that there's a significant amount spent in that last year, and the sort of conclusion discussion point of like, maybe we shouldn't be spending all that. But I can imagine that the providers are generally not thinking this is the last year, let's keep them out of the ED. Maybe sometimes, but usually that's because they're trying to keep them alive and they hope it's not their last year. So I wondered if there was any discussion around that and different conclusions that could be drawn.
Yeah, there is. And I think, on the programmatic side, in how we're phrasing the education system and talking about advanced care planning, talking about what services that you want, I think having those discussions sooner. So when you start to have a decline, yes, you might not know it's the last year of life, but making those decisions to say, no, I really don't want to be intubated. I don't want to go back to the ED with these certain things. So, our approach of trying to have the conversation sooner, not in a crisis, and not before you get that really scary diagnosis, and then try and do everything to save, being able to plan out that, understand your values, understand your wishes. If you want to try everything, that's your decision. But if you don't want to try everything and you want to be comfortable and have a good quality of what you have left, those are the discussions that you can have sooner with advanced care planning and more routine as you get different things diagnosed and different things happen in lives.
Makes sense. Thanks.
Yeah.
Well, thanks everyone for such a great discussion and really important presentations. And thank you to our audience for joining and for thoughtful questions. I think this concludes our session.
Yeah, great questions. Thank you.
Thanks.